Stand by. So let me just quickly again start the bidding and then get my colleagues into this. And by the way, we're going to have to, we'll just try to get bang, bang, bang. What's interesting to me in all of these presentations, which were very good and very responsive, is something that none of you emphasized a lot of, and that is that from a public health point of view, if you look at your state or your county and you look at your pre-existing health challenges that say, let's say Texas, Bruce, where your state doesn't do very well on the numbers of your residents that are physically active. So you have, you're very on the low end of the scale for other states. You do many other things wonderfully well, by the way. And so you'd say, wow, if we're going to be engaging in this process of recovery, we're going, and there's people that are doing housing and they're going to be reconstructing the streets, we're going to build in walk pathways, bike pathways, and so forth and so on. Can you all give us a sense of either A, are you thinking about the health rebuilding in the middle of as you are moving to your intermediate stage? Are you thinking about it? Is it not on the radar? B, are you constrained? Are the forces at play basically tell y'all to get lost if you try to raise it because we got other fish to fry, and go away? Give us a sense of why you're not bringing those things into why they weren't in your slides. And let's start Bruce and then Howard, and just real quick, and then we'll get the rest of the people in.
Okay. It really is something that we do think about. Dr. Lakey, my health commissioner in particular, is very much thinks about those things. But it really isn't a focus because we're so mission focused. And to bring those types of issues up to a community that's still reeling from a disaster, it would not be well received. And so it is important, but we really focus on specifically the immediate public health and medical needs. And once we get that box checked, then it really transitions more into the longer term mental health issues once we've assured that the infrastructure is back in place to take care of their medical needs.
Howard?
I think it's an excellent point, and I concur with what Bruce says. There's this rapid response to the situation at hand, and there's the issue of where the resources, particularly money, is going to go, and then everyone thinks down the road, well, what else can be done? The department is dedicated and committed to all the issues of these bigger, broader issues, and it would be great if it was part of sort of the response as we move forward. I think it would be helpful to do, and I'm glad to hear that you raised this issue. Thanks.
So I'm curious also when we will get Doug's response. So, but let me just signal to you that again, if you don't mind, and one of the terrible things you can possibly do in life is to come visit us because we're going to ask you for more. Sure. We have no conscience in that regard.
Got my pen.
So, just know we're going to ask you to drill a little further offline into this, and especially as you focus on the intermediate. Bruce, you were very precise on the short term. You irritate the heck out of the people. Granted, I accept it. I withdraw on that. I want to move you to the intermediate stage. And so again, Howard, it'll be that sense of why is it even in the intermediate stage we can't why don't these things come forward? And what can you teach us about that? Doug, any input from you?
Well, I would agree. We're so mission focused on handling the emergency at hand and restoring things to where they were. I think there's some policy level things in there too, because if a building or structure is taken down, even in the personal recovery things, some of the insurances, in the FEMA, they're only going to restore it up to where it was before, and that's fair. So if a building is destroyed, et cetera, and you're going to rebuild it, and now you want to have a nice bike rack and connect it up with the trail out back, and you want to have active design in the building, that's great, should be encouraged. But that'll be up to the individual constructing it. And again, in the long term, when I say restore us back to normal, so then we can get back to those how do we promote health in the community? But we really have not connected it up with the recovery activities itself.
Howard, let me just push you also just again on specifics. So one of the, I'm reminded of this since Doug reminds us about this new normal that that Irwin even had in his deck. You talk about this very interesting e-fines system. So you've got this patient tracker. So if you sort of think about long-term needs for the community for health, it's the ability to move information about a person from setting to setting to setting. This is a generic function that could be very exciting. It's critical, as you indicate, for the crisis situation, and then it's also critical for being able to track the primary care specialist needs over time. So it would seem like that would be a wonderful opportunity to move from a crisis to a new normal, where you actually have an interconnected health information system that builds on it.
Well, two things. One is I just wanted to respond to the other question because I remembered there's also a Healthy Cities report that the New York Academy of Medicine put out, which may tie in a little bit to some of the questions you raised before. So I just wanted to mention that because Joe Ivy Buford and I were talking about this just the other day.
So Joe Ivy Buford has that. So the notion, and that's exactly it, is so you take Joe Ivy Buford's report there. So this is, and either you respond now or again offline. We're not trying to,
okay.
This is not 60 Minutes, kind of thing. It ain't this kind of game. But what I'm getting at is that, but being as practical and concrete as I can be, is if you sort of had that report and this is what we really need for the city to build a healthier city. Now you've got people saying, we're going to redo this housing plan and we're going to do this urban community plan around the crisis. You're going to go, oh, wait a minute, I got this blueprint here. Don't design the streets to go all left and crooked. They're supposed to go right and straight. Right. You see what I'm getting at? What would happen if you dropped that into the intermediate stage? Would they hate you and fire you, or would they see this as an opportunity?
Probably see it as a great opportunity to try to move this forward. But I will get back to you on that. On the e-fines issue, yes, one of the things what you bring up is absolutely what we're trying to do is to tie the e-fines to not just an acute crisis, but for other situations. Bruce had brought up the issues about medicines and the little white pill issue, and that was one of the things that we were also talking about with the e-fines is how can you have information there so that when that situation happens, you actually have that data so that when someone goes to whether it's a special needs facility or anywhere or to another hospital, at least you already have that information. So we are trying to build the e-fine system out further, both for the acute situation, but also this would be very helpful as it ties into just electronic medical records and other informations.
Good. Yeah. Any other colleagues want to get one in? Steve.
I wanted to direct this to Bruce and Howard, I think more specifically because you sit at the crossroads of, we've talked about funding in the previous presentation, and it's been brought up in presentations here, that you're at the crossroads where you have multiple federal agencies bringing money into the state, and then you have to distribute it among state agencies and also down to other layers of government at the local level. And it's obvious when you look at the magnitude of this why sometimes it's hard to spend the money or money gets left on the table for long periods of time. And I was wondering if you wanted to make any commentary on that situation or any specific recommendations that might help that process.
I'm going to get back to you on that exactly where, because I'd like to know, I'd like to first check and know exactly how much we have, what was left on the table. And part of the challenge of this is that a lot of times after disasters, a lot of money comes in, and I've seen this not just in the U.S., but in global health issues as well, where a lot of money gets directed to an area, and then it's like, how do you actually channel it to the right resource and don't have duplication of efforts that are being made. The Sandy money, I'd like to get you a number for that, but I'd be glad to get back to you on the exact amounts and why some in response to your question, why specifically some of this funding may not move forward.
I think it's more of a general question about the difficulties more than the specifics of any particular incident, just how difficult it is because of different budgetary cycles, different rules for spending, and all those sorts of things.
Well, I guess one part of that is that you brought up when the issue of Sandy, there's a city budget, the city health department issue, and then there's clearly the state, and there is overlap of needs and what falls in which person's responsibilities, and I think that sometimes slows things down a little bit, at least for Sandy.
Do any of you, oh, Bruce, go ahead.
I'm sorry, from the state perspective as far as public health and medical, first of all, we don't have really any additional funds because everything that we do is based on what we call a STAR request, a state of Texas assistance request. It's very specific, and we have to validate that they have the need, and then we fill the need. So there really isn't anything extra, but I would like to say this, that the importance, the critical nature of having the public health emergency preparedness and hospital preparedness funding, and the fact that the people who really know how to carry out the response and recovery activities and who shepherd that whole process are essential, and they're funded by those programs. We're seeing, especially on the HPP side, some of that apparently dropping very quickly, and we're going to start losing key staff, and our ability to respond effectively and to recover effectively could be impacted by that. Although we can't spend those dollars on response and recovery, the people who carry the expertise are in those programs.
Barry, Bruce, let me push you on that. So one of the things that Barry keeps teaching me is that there's often a disconnect between the language that the health people use and the planning people, that they're different disciplines, they're trained differently. So if am I overreading you when I'm thinking about the STAR request? So here the health guy or gal is going, we need this for health, but the people making the decisions around the money, no, I don't know that stuff. What I deal with is bridges, I deal with a whole nother engineering taxonomy. You people are talking about stuff that I'm not sure I understand. Is it difficult in real life for the health message to be communicated, the urgencies, the issues that you're worrying about, to be communicated to the planning people, the political infrastructure people, the appointees in these positions, once you get past the everybody's going to die part, once you get past the easy, now you're just out of that phase. Are these two different cultures that are hard to make mesh together?
Well, first of all, if we put it in the context of an actual response and recovery of an event, the way that we do that translation of the medical need and the public health and the planners and folks who are oftentimes responsible for ESF 8 response but not always real knowledgeable of the medical side, we deploy MIST teams. It's medical incident support teams, and so it's really knowledgeable nurses, paramedics, and others who can interpret the responses or interpret the requests that are coming in and translate those oftentimes to people in leadership positions on the public health side. So we have that translation piece during response and recovery. What's really helping us now bridge that gap between public health and planning and the medical community is the healthcare coalitions that have been building. There is involvement from public health and from medical, and really that's where a lot of that translation during preparedness activities, that's where that happens now.
I thought I might have had Doug make a rattle there, so let me just make sure, but we're closing out. But Bruce, before we let Doug rattle again, Daniel keeps trying to teach us that, you should have been here for the last meeting, God was he good, that in addition to the money side of it, that resiliency is very much based around the bonds of a community and how communities interact with each other. So I wonder whether you if you have some observation based on your last point, that one of the good attributes that theoretically that public health has is prior planning of community engagement, where communities talk about needs assessment and so forth. Do you have any experience or any observations on this idea of community social cohesion as a solution to some of these problems that is disconnected and not connected to the money flow per se?
I would bring up one of the issues, something I worked on before, which is the need to have a community come together in a non-crisis situation. And the whole Medical Reserve Corps issue was the the plan to bring a community together over issues of whether it's obesity or diabetes or other problems with smoking, so that when there is a crisis, they already know who the other person is in their community, that then if they have to respond, there isn't this sense of maybe sometimes mistrust, or you work at X hospital and I work at Y hospital, and I think that is a way to bring a community together, and not just bring the medical part of the community together, but others, whether it's communication, housing, or other parts of a community together. And I think that's a way that you could troubleshoot sometimes part of the problem.
Thank you. Doug, did you want to, I think I heard an electronic beep from you somewhere.
Well, I was just going to amen the comment about the public health in response, the FEP and the HPP funding. That's going away, and I know the theory behind that was, okay, we'll be geared up now and we can handle these things a lot more on our own. But when you pull that basic infrastructure away, let me go back. The only reason we were able to respond so well and things worked well and we didn't have a lot of claims, post, is because we had the infrastructure, the training, the support was there. But if that goes away, then we start to we're going to start to lose personnel. We're going to start to lose training, and when a disaster strikes, we're going to be in a worse situation further down the road. So. It's an old public health philosophy. If we invest now, it's going to save us down the road. So, I don't know if we can make that political pitch to look over that preparedness funding, but also the community cohesiveness. Absolutely, the work that we've done to know who our partners are made it so much easier to respond, and we had much the same experience that I think you mentioned. It was in Texas. There, I forget the number of people displaced by the floods. We opened up shelters, and I think our largest census, there were 12 people at one time, because they knew where else in the community to go, friends, family, and then it gets to the decision making, that we know how to get together, make decisions, look at the data. And we know each other on a first-name basis, so it made the recovery a lot easier.
All right. Well, thank you all. We're going to have to move to the next panel, but one before you feel like Columbo here. But just one more thing, for Autumn and for Lauren, if we could, in addition to bugging you about the questions that we've already presaged, we want to ask you. Erwin made some good comments at the beginning around the importance of being able to do metrics in evaluation. So we would like to sort of get a sense, you described pretty nicely that, you had like 5, 9 mobile health units, engagement with federally qualified health centers. Each of you had things that you were proud of that you had done. The question we would probably like to also get from you is any guidance around, okay, how do you know that was enough? Or how do you know, kind of like, good for you, yay, you did great, you got 9 vans out there, go for it. You needed 15. How do you know when you've achieved something that's good? And not good. So try to help us with that. And I hope that, that there's a way in your political infrastructures where you can, actually guide. This is the Institute of Medicine of the National Academy of Sciences. Nobody, we hope that we can immunize you from having to, the political realities of only saying good news and just giving us a bunch of crap. So do your best. I mean, we're from the government. We're here to help. Thanks a lot, everybody. And we're going to have the next panel right away because we are relentless. And the break comes after those panels for those that are worried. In our relentlessness, we are going to welcome Louis Goldfrank. Scott, are you on by phone, Scott Mayton?
Yep, I'm here.
Good. And Betty, and I'm not even going to try until you get there. She's on the phone. Betty, you're on the phone?
Yes, I'm on the phone.
Hey, Betty, why don't you, I could do it, but I don't want to show off. Would you tell them your last name?
Efferbaum.
That's what I said.
Silent.
All right, Pfefferbaum. And Doug Walker, are you here?
I am here.
Doug, you're very much here. Okay, great. Well, listen, this is a session on medical systems. And so we've, just for those that are tracking, we had public health. Now we're moving to medical. After the break, we will do social services and so forth. So there's an inherent logic in this somehow. For the three phases of recovery, again, we want to examine what we can around the funding sources and the pathway by which those sources are getting there, along with the non-monetary resources of social capital and volunteerism and so forth. We are curious about the decision-making processes for health service delivery activities that are either related or independent to the funding pathways, and then the practical lessons learned that are relevant to maximizing health outcomes and how those lessons translate into recommendations for enhancing the effectiveness of medical and psychological support services in the multi-stakeholder process of disaster recovery. To start our process, Louis Goldfrank, who many of us know from other committees, is the Director of Emergency Medicine at Bellevue Hospital Center and New York University's Hospital. Louis, thank you for coming.